not all of the practitioners are able to perform scleral lenses. So this is a very under touched topic. So in order to start a practice with scleral lenses, it is really very important to understand for all of us that how do these lenses work. And in order to understand how do these lenses work, we should understand how is the lens made, what is the anatomy of the lens. Because once you understand that, and then after that you can understand what to look out while performing a scleral lens trial. So today basically I'll be talking about a few things. The number one will talk about the terminology of the GP lenses, and then we'll talk about the nomenclature of scleral lenses. The next thing what we'll learn will be the anatomy of the scleral lenses, and the last thing we'll learn is the implications or the indications of the scleral lenses. Now, as I told you, that anatomy is a very important factor to be understood. So today we'll be talking about the nomenclature. We'll be talking about the anatomy which has been put forward by the Scleral Lens Education Society. And this is a very standardized nomenclature what we are going to be learning today. So apart from what you read today or what you hear today, you might come across some other terminologies as well in some other papers or some other books, or companies insert lens inserts and so on. But if you can remember the terminologies what we learned today, you are speaking a global language of scleral lenses, because all the terminologies have been put forward by the Scleral Lens Education Society. All right then. So we should remember one simple thing, that all the scleral lenses are manufactured by the gas permeable, are made up of uh, gas permeable materials. So the materials what is used to manufacture the RGP corneal lenses, the similar material is used to manufacture the scleral lenses. Now, GP lenses could be of various types. So let's understand the nomenclature of those. So if you can see over here, there's a concentric circle which is drawn on the slide. The first, the innermost circle, what you see is the cornea. So basically, any GP lens which is sitting on the cornea and not crossing the limbus is something known as a corneal GP lenses. That is the normal RGP lenses in general terms, what we call. So these are the corneal GP lenses. The second would be something known as a corneoscleral lens. Now, basically, according to the definition, it says that it restly parts, it partly rests on the cornea and partly rests on the sclera. However, in practical world, when you're fitting such lenses, you do not avoid any, you do not allow any touch on the cornea or on the limbus, because that is not what we want. So basically, practically, you don't allow any touch on the cornea or on the limbus. However, according to the definition, corneoscleral lenses means it rests partly on the cornea and partly on the sclera. The next would be something known as a mini scleral lens. Now, mini scleral lenses are nothing but these lenses land. They have their landing zones which are up to 6 millimeter beyond the HVID. That is, so 6 millimeter does not mean 6 millimeter 360 degrees, but it is 3 millimeter on each side. So up to 3 millimeters on the nasal side or up to 3 millimeters on the temporal side. So if you find such a lens, or if you're fitting such a lens, then it will be termed as a mini scleral lens. And the last one is a large scleral lens. That is when the landing zone is more than 6 millimeter away from the HVID. Now again, it is not 6 millimeter on each sides, but it is 3 millimeters. It is more than 3 millimeters on temporal as well as on the nasal side. So generally, this why are we just talking about HVID and not VVID, or else why not about the diameter of the cornea? Because we all are aware that HVID is longer as compared to the VVID. So, and basic rule of a scleral lens is that the landing zone should be at least 2 millimeter away from the limbus, at least 2 millimeter away from the limbus. Hence, we consider the longest measurement, that is the HVID. Now you may come across some literatures or some company terminology that some mini scleral lenses have got this diameter, large scleral lenses have got this diameter, corneoscleral has got this diameter. So basically the terminology is very much different. So you got to adapt yourself with the internationally accepted as well as with the locally or the terminology which has been put forward by the different companies, but we'll be focusing on what is put forward by by the Scleral Lens Education Society. I personally follow this specific terminology. So we all know that this is a corneal RGP lens. So this is basically not crossing the limbus. As you can see this, everyone has seen this kind of an image once in their life, at least during the college days. Okay, so on the left side, on the left image, what we can see over here, these are two images. These both of these are scleral lenses. On the left, what you can see is a corneoscleral lens because the distance between the limbus and the landing zone is not more than 3 millimeters. It's within 3 millimeters over here, if you can see. Whereas the image on the right side, what you are looking at is a mini scleral lens. As you can see, there is a considerable uh, difference in both the lenses. And if you can see over here, it is much far away from the limbus as compared to the CSL lens on the left. So the right lens will be termed as a mini scleral lens. The left will be termed as a corneoscleral lens. Now this is a full scleral lens. As you can see, the landing zone is far away from the limbus. So yes, it will be termed as a full scleral lens, and you can get lenses as large as 28 millimeters of diameter in full scleral lenses. So in most of your cases, now you know a lot of us might be having a doubt that in what cases should we choose which kind of a diameter. So let me tell you that in suppose if you are having a specialty practice, so I think approximately 50 to 60% of your patients are eligible for the corneoscleral lenses. Now, suppose if your patients are not eligible for corneoscleral, you go for a mini scleral. And suppose if they are not eligible for that, and then you go for a full scleral lens. Why do we keep the full scleral lens as a last option? That is because it is a little bit difficult to fit, and as well as it is a little bit difficult for the patient to insert the lens in their eye, right? Because it's a pretty large lens, and you know it specifically gets difficult for Chinese ethnic people, Southeast Asians, including Nepalese people, because because the fissure height is pretty less, and it makes it a challenging task for the insertion of the lens. I'm not saying that the people cannot insert the lens in their eyes, but it's a challenging task. So for some spectrum of your patients, this factor may be a demotivating factor for accepting the scleral lenses. So you got to choose the diameter of the lens very vigilantly. You should take a lot of things into consideration before choosing a lens diameter. So before we go on, I would just request the organizers to, I hope, have you announced about the poll? So we just require a count of people who are practicing and not practicing sclerals from our participants. So I would please ask the organizers to keep a count after like 20 minutes or something. We give time for to the participants to answer whether they are practicing or not, and then you can just tell me the numbers. Is that fine?
Uh, sure, sir. Sure, sir. We've already asked the question in the conversation box. I would like to ask again. Please answer in the conversation box if you are or are not into scleral lens practice. So we'll be counting, and the results of poll will be uh, discussed later.
Yeah, definitely. Thank you very much. All right, so we'll move to the next chapter, that is the anatomy of the scleral lens of a scleral lens. So basically, it is divided into four areas. Number one is something known as an optic zone. Second is mid peripheral zone. Third is an intermediate, and fourth is a landing zone. So this is how it is. So on the right side, what we can see, this is the lens how it appears from the front side. So in many of the lenses, you will in all the lenses you will see a demarcation for the optic zone. Okay, but you may or may not see the demarcation of mid periphery zone. Now, many of the manufacturers do not manufacture a lens with an exclusive mid-periphery zone. So this mid-periphery zone is either blended into the optic zone or it is blended into the intermediate zone. So here is this cross section of a scleral lens. So if you can see, it's the center is the optic zone, which is correlating with this region in the right image. Second is the mid-periphery zone. So the name itself is suggesting that it is in the mid-peripheral area. There is no rocket science to that. The third would be an intermediate zone. Now, this is again an important zone. We'll come to that. And last is the landing zone. Landing zone is the area where the lens is in interaction with the ocular surface. All right, so we'll talk about the optic zone. Optic zone can also be known as a central zone or clearance zone or base curve radius zone, and it has got n number of names if you can see on the right side. So these are the different names which are used by different manufacturers, different lens manufacturers. So you really got to be aware of what terminology is a specific company using. Right, but let's understand the science of it. Now, what is an optic zone? Optic means light refraction, right? It deals with the refraction of light. So, optic zone is nothing but an area where the refractive power of the lens is present. Now, how is the refractive power of the lens present? It is basically there are a few measurements which are known as a front optic zone radius, and there is something known as a back optic zone radius. Right. I believe that if anyone is practicing RGPs, you might have come across these terms previously. But yes, I'll tell you what is it. So the difference between the front optic zone radius and the back optic zone radius, this leads to a creation of the refractive power on the lens. So let me tell you one more thing, that scleral lenses can be available in monofocal designs. It can be available in bifocal or multifocal designs, and it can have center near and center distance designs as well. It can have aspheric optics, it can have spherical optics, it can have toric optics, and so on. Right, these are the few optics that are available in scleral lenses. So, it is the combination of the radius of the front optic and the back optic zone which creates the refractive power. Right, and you should remember one more thing, that if there is a cylindrical power which has to be given, it's always on the front surface and not on the back surface. Right, so there are two more measurements, which is something known as a front optic zone diameter, back optic zone diameter. As we can see over here, there is a cross section of a scleral lens. So this central region is the optic zone. So basically the diameter of the front optic zone. Okay, the diameter of the front optic zone will be known as the front optic zone diameter, and the diameter of the back optic zone, that is the base curve, will be termed as back optic zone diameter. Now, what are the other importance of an optic zone? See, basically, optic zone is large enough to cover the whole pupil. However, in some cases, if the pupil is displaced or there is a large angle kappa or something like that, then in such cases you got to have a decentered optic zone. Or if suppose if a pupil is displaced and you want to give a multifocal to the patient, you got to again displace the optic zone. So, there are a lot of implications and a lot of manipulations can be performed in the optic zone. But let me tell you, I'm not sure what companies are present in your country, that's in Nepal. But in India, we have a very limited number of companies which manufacture scleral lenses. And, I think seldom any company can do such manipulations. But in European and the Western countries, I've got access to these kind of designs. Another reason why we don't have such lenses over here is again the economic status of the people and the coverage by the mediclaim companies. So there is one more hurdle which comes into play. However, we'll not be going in depth about those things. Right. So coming back to the same thing. So yeah. So let's talk a little bit about the back optic zone radius. So back optic zone radius, as I told you, we have come across this term in while learning RGP. So what does back optic zone radius does is in RGP it is used to fit on the cornea, but we should remember one thing: in cases of scleral lenses, we do not use this term to fit on the cornea, because we all know that the corneal RGPs are sitting on the cornea, but scleral lenses are not. They don't have contact on the cornea. So the main purpose of having a back optic zone radius is to create a refractive power. Now another purpose of back optic zone radius is that you sometimes in some cases you need to give an oblate design of the optic zone or a prolate design of the optic zone. Now before I tell anything about prolate and oblate, can someone from the crowd please tell me something about corneal shapes? What are the different shapes of cornea what we see? Can we have someone to comment on it?
Prolate shape cornea. Corneal shape is a
Okay,
prolate.
okay. And
Crato,
can we see cornea with
Cratoconus.
some? Yes, yes, very good. Can we see cornea with any other shapes?
Globus, globus cone in
Okay,
keratoglobus.
okay,
Inferior steepening in the TMCD, superior steepening in the PMCD. Sorry, TMCD
okay.
superior, TMCD
TCD,
inferior
right.
steepening.
Okay. Any other shapes can you please mention?
And post refractive ectasia conditions.
Very good. Perfect.
Mhm.
All right.
Pellucid like keratoconus also the conditions.
Very good, very good. Great input. I'm really happy about this. So yes, as you said that people can have keratoconus or keratoglobus. There could be a post-LASIK ectasia, and so on. So these kind of conditions give cornea some a different kind of shape. So let me tell you that cornea is an aspheric structure. Right, we are all aware of it. So what is aspheric structure? It is steep from the center, it flattens towards the periphery. That is
Right.
what an aspheric structure is basically. So this is the exact shape of the cornea would be known as a prolate shape. Okay,
Mhm.
prolate means again steep from the center and it is flatter towards the periphery. Now suppose if a patient has got keratoconus, so this steepness increases, right? So the cornea will become something known as a hyperprolate cornea. Okay, the shape will go towards an hyperprolate side. Okay. On the other hand, suppose if a patient undergoes a myopic LASIK, suppose a patient has got myopia and he undergoes LASIK or any other refractive correction on the cornea, so that will cause the cornea to flatten in the center. So when the cornea is flat in the center and steep in the mid periphery and the periphery, so it is something known as an oblate cornea. This is an oblate shape. Okay, so you observe oblate shape in post myopic LASIK, post myopic SMILE, post myopic PRK. You see in is such designs or such appearances in RK patients, post RK patients, where the mid periphery and the periphery is steep as compared to the central region. So all these cornea will be known as oblate cornea. And the other shape, as I was telling you, hyperprolate, hyperopic. Suppose if a patient undergoes a hyperopic refractive correction on the cornea, so it will cause the cornea to become hyperprolate because it is steeper in the central region and flatter in the mid periphery. So before you fit a scleral lens, you should be well aware that well aware of the corneal shape. And we should also remember one thing, that purpose of any kind of a contact lens, be it corneal GP or be it a scleral GP, be it a limbal GP, and so on. So what our target is to follow the contour of the cornea, match it as much as possible, and try to cover up all the irregularities which are present. So suppose if you're fitting a cornea with which is hyperprolate, and your back optic zone radius is a flatter on a flatter side. Okay, the patient may get good vision. On the vision chart you will see the patient is reading zero point 0.0 logmar or probably 6.9 or something like that, but the patient will say that no, I'm not really enjoying my vision. It is better than before, but I'm not enjoying it. So this kind of comments you might get. So this is because the surface of the lens is not really matching the surface of the cornea. I'm not saying that you have to create an irregular lens, irregular surfaced lens. However, you should try to match it as much as possible, right? So what you gotta do is, in such cases, you have to play around with the radius of curvature. That is the base curve, that is the back optic zone radius, which is over here. Now let me tell you one thing, that not all the companies allow you to play around with the back optic zone radius. Right. So in cases when you have oblate cornea, so you try to make the lens as oblate as possible. Along with it you have to maintain the sagittal depth. Now what is sagittal depth? I'll come to it in a moment. So first things first, you got to remember is that you have to maintain the back optic zone radius, right? You have to change it according to the status of the cornea. Now let me tell you something about the sagittal depth. Now what is sagittal depth? It is literally, it means what? Now suppose if this is a lens with its convex side up, it is placed on a surface over here. Okay, so the distance between the surface to the posterior surface of the lens, that is the back optic zone back optic zone, the distance between that is something known as a sagittal depth. Okay, so when you are measuring from the back optic zone to this reference plane, then it will be known as a sagittal depth. And when you are measuring from the surface to the back optic zone, that will be considered as a sagittal height. Now let me tell you, both the terms are interchangeable. You can either use sagittal height or you can use sagittal depth. It does not matter. Both of the things are going to mean the same. Okay, now some of the companies, they don't just they don't mention the radius of curvature, but they mention something known as a sag. Sag is just nothing but sagittal depth of a lens. Okay, and there are some companies which mention radius of curvature as well as they will mention the sag. So you can manipulate both of things. Or else some companies will mention only the radius of curvature. So you have to be sure, you have to be aware of what terminology is the company using, and what things are they mentioning. And you got to understand that whether they allow you to manipulate the radius of curvature as well as the sagittal depth, because there are some companies which will mention both the things, but they don't allow you to manipulate the radius of curvature while using the specific sagittal depth. So both of the things go hand in hand. So there are different algorithms which all the different companies are using in their systems. So you got to be aware of that. So you have to remember that back optic zone radius, sagittal depth, the front optic zone radius. So these are a few things which are extremely important while fitting a contact lens. These are the readings which are going to take care of how high or how away is the lens from the cornea. That is basically how big is the vault. Now what is vault? Vault is nothing but the distance between the posterior surface of the lens to the anterior surface of the cornea. That is known as a vault. So any manipulations, physical manipulations you make in the optic zone, that will lead to change in the sagittal depth, and any kind of a radial changes you make in the optic zone, that will lead to changes in the profile of the optic zone, that is oblate or prolate. As well it will lead to the change in the refractive power. You can also manipulate the diameter of the optic zone as well as the position of the optic zone. Now, one more thing that we should always remember is that the sagittal depth or sagittal height of all the manufacturers are never the same. Suppose if a manufacturer tells you that an X lens has got a sagittal depth of 4.09, that does not mean that that 4.09 lens is interchangeable with any other company's 4.09 sagittal depth lens. because the way they manufacture, the way they have their measuring ways are pretty different as compared to the other companies. That is because, if you look at a yellow lens over here, and if you see the black lens over here, right now both of the lenses have got equal sagittal height. However, if you place both the lenses on the cornea, they will they will show very different vaulting, because if you can see the yellow lens, it has got less curves. Posterior surface have got just one, two, and three curves. But if you can see the black lens over here, it has got one, two, three, and four curves. So if you place both the lenses on the same eye, the yellow lens will show a more vault as compared to the black lens. That is because of the presence of extra posterior surface curves. Now, what do these curves means? We'll come to that on a later stage. However, we need to understand that sagittal depth of two different companies are not the same. All right. So, what terminologies will you use when you're talking about the vault? So, when you're talking about the vault, you gotta say it is either high or low, or else you can use the word steep or flat. I personally like using the terms high or low, because if you talk about steep and flat, it goes towards, changing the profile of the optic zone and not the vaulting of the optic zone or the vaulting of the scleral lens. So, you always try to stick to the high and low when you're talking about the vaulting. And when you talk about the back optic zone radius, at that time you can use the terms which are steep and the flat. Right, so this is a little bit about the optic zone, and yes, one more important factor that can be manipulated in the optic zone is the thickness of the optic zone. Now, suppose if the optic zone is pretty thin, it might cause flexure of the lens due to forces of the upper lid. So that might lead to unpredicted cylindrical power, and it might even lead to, on the long run, it might lead to easy breakage of the lens as well as if the central thickness is very thick, it might lead to reduced oxygen exchange from the central region. So in such cases, you gotta ask the company or the manufacturer to manipulate the central thickness. Now again, you have to remember that if you deal or if you play around with the central thickness, definitely the BOZR and the front optic zone radius are gonna change. So you have to be very cautious about it, and you should understand that what changes you will make and what impact are they going to have on other parameters. So these are a few manipulations that you make, which we already talked about all of it. I will talk about a mid periphery zone. Now, as I told you previously, and I'll just repeat it again, that mid periphery zone is not present in all the scleral lenses. They are present in a very limited number of lenses or very limited number of designs. Now, basically, mid periphery, it says itself that it's present in mid periphery zone. Now, basically, you make changes in the mid periphery zone only when when for example, you have got a case of pretty advanced keratoconus and the thinning is in inferior side, or you have got a very advanced Tyrion's dystrophy which is on the superior side, and it's not on the central region but it's in the mid periphery region. So in such cases, what happens is when you try to fit a scleral lens, you get a feather touch on the area of elevation, right? And you get excessive vaulting in the central region or in the region opposite to the apex. We are getting some disturbance.
Very sorry for the disturbances, sir. Again, requesting everybody to please keep your microphones turned off. Uh, very sorry, sir. Please continue.
Thank you very much. Yeah, so so as I was telling you that if you want to clear an extremely or advanced cones or extremely advanced ectasia, so you got to have a lens with a high sag. But when you fit a lens with a high sag, so what you get is you get a feather touch. Sometimes, I'm not talking about all the cases. Sometimes what you get is a feather touch at the region of the elevation or at the region of the ectasia, and in the other flatter regions you see excessive vaulting in such regions which you do not really want to see. So in such cases what you do is you try to manipulate the mid periphery zone without giving excessive vaulting on the areas which are flat, right? So in such cases you deal with the mid periphery zone. But yes, you got to be aware that whether mid periphery zone is present in a in specific manufacturer or not, or a specific lens or not. So yeah, as I told you, may or may not be present indistinctly, and it may be integrated with the optic zone or the intermediate zone. Now one more thing that you can add in mid periphery zone is something known as fenestrations. What is a fenestration? Fenestration is nothing but a hole. Okay, so it's nothing but a hole. If you can see over here, and over here in this image. So these three are very tiny holes. These are approximately maximum size of 1 millimeter. So yes, in such in some of the conditions you gotta give fenestrations. This is in order to increase the tear exchange, as well as in some cases it is to reduce the negative pressure which is present inside the lens when it is on the eye. Now what this negative pressure does is at times it causes something known as conjunctival prolapse. Okay, so we don't want any conjunctival prolapse to be occurring, and at the end of the day it causes too much of suction of the lens on the eye, right? So in such cases you don't want to see such things. So you provide fenestrations, and when you're providing fenestrations it should be in the mid periphery zone. It should be made in such a way that it does not cause any bubbles which obscure the visual axis. It shouldn't obscure the pupil. So the bubbles are inevitable. You will definitely see bubbles if you give fenestrations, but they should not obscure the visual axis. You gotta make sure of that. So basically, you need to give fenestrations more in patients whose conjunctiva are pretty loose, or who patients who have conjunctivochalasis, in technical terms. So in such cases, you gotta give, but till now I've never had to give any fenestrations. This is a theoretical thing what I've always came across, but I never came across any such cases in which fenestration had to be given. So what are the terminologies which are used? These are basically peripheral corneal zone, peripheral clearance zone, peripheral curve number one, and so on. Intermediate zone. Now this is an extremely important zone when you are using a corneoscleral lens. Intermediate zone can also be known as a transition zone or a limbal curve or limbal zone. Now this is the area which is. Can we please have the mic to be muted, please? Thank you. So, limbal zone is the area, or the intermediate zone is the area which is present upon the limbal area. But it is very important that you should have clearance over there. That is, it shouldn't be touching the limbus at any times, right? And there are different designs of scleral lenses. Sometimes the transition zone can be independent. That is, you can change just the transition zone without making any manipulations, or without having any collateral manipulations in the optic zone or in the mid periphery zone or on the landing zone. And there are some designs which are dependent on the other zones, right? So basically if you make any changes in the intermediate zone, so it will lead to an increment or a decrease in the vault in the central region. Okay, so you need to understand whether it is dependent or independent on the other parameters of the lens. This company person can provide you information about. And we should remember one important thing is that it should run parallel to the corneoscleral angle. Okay, it should not match the corneoscleral angle, but it should run parallel to it. Because if you cause it to be similar to the corneoscleral angle, it will lead to a very sharp angle with the landing zone, which will end of the day lead to impingement or blanching of the conjunctival vessels, which we do not require, which we do not need. Actually, not about requirement, we don't want to see such things. So it should run parallel to the corneoscleral angles, and you can use terms such as steep and flat in that, or the companies have got their own terms. Many a times they might talk in angles, they might talk in some numbers which do not have any units or something like that. So if you can see over here, let's have a look at a few photographs of it. So if you can see over here, you can see a very dark ring which is encircling the central region. So this is the limbal region, and in this case, the transition zone is pretty flat. That is, it is touching the limbus 360 degrees. So we do not want such kind of fit. So in such cases, we will steepen the limbal zone or the transition zone. In the next case, what we see over here is in the inferior region, there is no limbal touch. However, you see a limbal touch in the 9 o'clock region, the horizontal regions. So over here in such a case, if you are unable to increase the clearance of the transition zone, that is steepen the transition zone, if you cannot do that, then you got to increase the size of the scleral lens, that is increase the diameter of the scleral lens. And the last image what we see over here is, if you can see this band over here. So this is a very good clearance which it is providing. This is ideally how it should look like. Right, so transition zone is extremely important because limbus, you have to respect the limbus. Never ever let the lens insult the limbus. Because if anything happens to the limbus, the corneal and epithelium is going to be affected, and you will, instead of reducing the problem for the patient, this lens will end up increasing the problems and complications. So you got to be very vigilant while doing that. Now before we go ahead with the lending zone, I would like to ask, have we got answers for our poll? If you can just comment on that.
Yes, so we have certain numbers. So maximum of our participants today are not the scleral lens practitioners. We have around 5 of the people who are scleral lens practitioners and around 20 to 30 of the people who are not.
All right, all right. So we are talking to people who are not experienced in the same. All right, this is a very good learning opportunity for all of us. Thank you very much. I'll just carry on further. Landing zone. Now, this is a zone which is really, really, really important because this is where the lens touches the cornea. Yeah, lens touches the sclera. Pardon me, not the cornea. So basically you have to be really vigilant when you are doing a scleral lens fit. So it is not just the vaulting in the center or the mid periphery or the periphery, but also the landing zone, which is extremely important. So first things first, you got to remember that it should not be a perfect shape like the sclera. Never ever, because if you make it to be a perfect shape, it might cause conjunctival blanching, or it might cause bubble, and it might cause in some cases impingement as well. So you should remember that the landing zone should run tangentially to the scleral shape. Okay, there are many types of landing zones which are available. So it is basically divided into two regions. One is symmetrical, one is asymmetrical. Symmetrical includes spherical and toric. Can we please have the mic muted, please? It's a humble request. Thank you. So, we have symmetrical and asymmetrical types of landing zones. The symmetrical includes spherical and toric, and asymmetrical has got regular as well as irregular. There are different terminologies again, scleral zone, scleral curve, haptic, and so on. Now, before we go ahead, let me tell you what do we mean by toric. There are two types of toric lenses, scleral lenses available. One is something known as a front surface toric lens and back surface toric lens. So you should know the difference between the two. Both of them are not similar terms. The front surface toric is associated with spherocylinder correction, so that is associated with the vision, and the back surface toric is associated with the fit of the lens. So the back surface toric has got nothing to do with the optical performance, but it is got only to do with the landing zone. Right, so you got to be very clear with these two terminologies. Now let's talk about the spherical landing zone. Spherical landing zone, it simply means that the landing zone is equal 360 degrees. Okay, you cannot manipulate it locally, but if you make any manipulations, there will be a change in the 360 degrees landing zone. Okay, so we have to flatten or steepen based on our observations. Suppose if blanching is present in the lens edge, then you flatten the landing zone, and you have to steepen it when you see blanching inside the lens edge. Okay, so these landing zones, as I told you initially, that large scleral lenses are difficult to fit. Why are they difficult to fit? That is because the toricity of the sclera. Now with the photograph what you're seeing over here, this is nothing but scleral topography of an of a few eyes of 96 eyes. A very beautiful job done by the Pacific University. So if you can see, this is the cornea, and this is up to, I think, up to 3 millimeters radius. So if you can see, if we compare between two areas, so this is 38.3 on this side and this is 38.2 on this side, so there is not much of a difference in this scleral profile when you are not far away from the cornea. So there is a difference of maximum difference of 2 degrees. But once you start moving away from the sclera, when you go more towards the periphery, when you start, moving away from the limbus, you see that there is a lot of discrepancies in the uh, correlating regions. If you can see over here, this is 36.8 and this is 41.5. This is almost 5 degrees. Now, if you place a scleral lens, a full scleral lens with a spherical haptic, so it will be flatting. It will be fitting very differently over here, and it will be fitting very differently over here. So you might see that there is a localized blanching or localized impingement or localized bubbles and so on. So we have to remember that whenever you are using a corneoscleral lens, you can have a spherical haptic or spherical landing zone. Once you start moving away from the limbus, once you start moving away from the cornea, you gotta start using other designs of the landing zone. Let's go towards the toric towards the toric haptics or toric landing zone. So toric is nothing but the haptics are flat in one meridian and the haptics are steep in one meridian. It's as simple as that. It is just like your refractive error. Okay, it has got nothing to do with your optical zone. Okay, so it is not your optical correction. This is just the landing zone. Okay, so in one region it is pretty much raised or flat, and on one region is pretty much depressed or steep or or tight. So let's have a look at one of the toric lenses, and you have to remember that in toric haptics the changes are at 90 degrees apart. So at 90 degrees it is going to be steep, at and 90 degrees apart, that is at 180 degrees, it is going to be flat. So if you can see on this, the image A on the left side, you can see over here this region, it is raised from the surface. So this raised surface is nothing but a flat region. And if you can see over here on the B image, if you can see this is touching the surface, that means it is a steep region. Okay, steep region are always touching the surface, flat are raised. I'm not saying this is going to be raised above the sclera, but it is going to follow the scleral profile over here because the sclera is flat in this region. Right, so this is something known as a toric haptics or toric scleral lens haptics or toric landing zone. Now let's talk about asymmetrical regular haptics. Okay, so this is nothing but this is something known as quadrantic, or you can make changes in quadrants, and you can make changes in o'clock hours. So suppose if you are getting a localized blanching at 3 o'clock, so what you do is you can just make a manipulation at 3 o'clock and you're done. You don't have to do it at 90 degrees apart from each other. So all the areas of the landing zones are independent of each other. So in such cases, you just have to tell the company, okay, I'm looking at some blanching at 3 o'clock, and this is the photograph, this is the anterior OCT. Please guide me what to do, or else please flatten this much. So all companies will have their own ways of measuring the landing zone. Some might have angle in degrees, some might have the standardized numbers. They just give you 1, 2, 3, 4, 5, 6, 7, 8, and you just gotta choose that which landing zone number you have to fit. Some might give you microns. You just have to tell them, okay, I have to make changes at 70 microns, at 3 o'clock or 8 o'clock or something like that. So this is for extremely localized regions. Okay, and let me just show you how they look like. So this is a very beautiful and intelligently made lens. If you can see over here, this region is flat and raised. This is a raised region. If you can see over there, this is a steep region. So these are not 90 degrees apart. These are all customized. So you have to take a choice. You have to make a choice of what kind of a haptic you want to give to a specific patient. So these kind of changes you generally observe clinically on the slit lamp, as well as you can see on the anterior segment OCT, and you take a decision on what kind of haptic you want to use. Okay, the last type of the haptic is known as an irregular haptic. Now these are used when the patient has got pengincula, or probably post glaucoma surgery, a blab the patient has got, or pterygium is there, so you don't want to touch those areas. Okay, so in such cases, what you can do is you can make channels. Now these channels are made, if you can see over here, channels or tunnels or breaches. These are basically to increase the inflow of the tears. Second, what you can do is something known as making a notch, and there is something known as a microvault. I'll show you how each of them look like. Yes, so I'll just show you how the channel looks like. Channel is nothing but it's kind of a tunnel which is made on the posterior surface of the landing zone. So an extra opening is performed. If you can see in this image over here, if you can see this line over here, this is a channel. So what it does is it allows the tears to pass underneath the through underneath itself, and then there is a localized pulling. If you can see over here, so that's how it is. This is the channels which facilitate inflow of the tears and fresh tears basically. Second would be something known as a notch. So notch is basically nothing but a cut in the scleral lens. So the area is pretty much cut, and then it matches the the contour of the irregularity on the ocular surface. This helps to avoid any touch on such regions. The next would be something known as a microvault. Now, in some cases, you cannot create notches, or you don't want to create the notches, or maybe the company cannot make it. There could be a number of reasons why will not go for notches. So, in such cases, you create microvaults. So, what you do is this area is a little bit raised. So, instead of cutting and staying away from the blab or the pinguicula, you just put up a cap on it. It's like a vault, so it does not touch it. It is just overhanging on it. It's not touching it. So again, it serves the purpose. How do we get these micro walls, or notches and everything? So there are two ways. One is you place a normal scleral trial lens on the eye, and then you see how large is the irregularity. You do the marking, you ask the company to make the changes, and the company gives you a final lens. Or there is something known as an impression technique scleral lens fitting. So a inert material is basically placed on the eye, and then it takes the shape of the irregular ocular surface, and this mold is then sent to the company. The company scans it with a laser, and a similar lens is produced, and it gives you the best customized outcome. So you can surpass all kind of irregularities on the ocular surface and the scleral surface basically. So those are the anatomy of the of the scleral lens. Now, what are the indications? So let me tell you, there are, see, you should never limit yourself in scleral lens indications. You can give scleral lens to a normal patient as well, right? If a patient is fond of contact lenses but they have developed dryness, you can easily ask them to go ahead with RGPs, corneal RGPs first. But if they don't want to tolerate the sensation of it, you can go ahead with a scleral lens. Similarly, if you have tried a corneal RGP for a keratoconus patient or high astigmat, he or she is not tolerating the sensation, go ahead with a scleral lens. Suppose if you are not able to fit extremely irregular cornea, or if you are unable to fit extremely steep cornea with corneal RGPs, or probably with the hybrid lenses, you can again go ahead with the different types of scleral lenses. Suppose if the patient has got graft versus host disease, arthritis, which is causing a lot of dryness, you can give such cases. You can give scleral lenses. You can give it to limbal stem cell deficiency. You can give it to sports players. You can give it for cosmetic purposes. These lenses are used in movies and everything, and so on. And nowadays is also used for therapeutic drug supply as well. So that's how it is. But let me tell you, your scleral lens indications are not limited to this short list. Okay, so as I mentioned, the sky is not the limit. So you have got n number of applications for scleral lenses. In other words, scleral is the new normal. But the only factor that comes into, there are two to three factors that come into play which causes underutilization of scleral lenses, is that the many of the practice most of the practitioners do not know how to perform scleral lenses. They don't know where to approach, how to go about. And next would be, patients cannot afford these lenses are pretty expensive, because there are patented materials and everything are present, so which makes the price go high. However, but as I told you, there are a lot of indications of the scleral lenses. So I think this is it. I would like to thank IBIDS for having me here today. Sridhar and Satyam, thank you very much for having me here today. And we can have questions now. If anyone has got any questions, please feel free to ask. And if someone needs any help in finding out companies who provide which type of scleral lens, any troubleshooting, please feel free to contact me. We'll be willing to help you in a lot of ways, to set up your specialty clinic, as well as if you have any doubts in your scleral lens cases, we can help you extensively. Thank you very much.
Okay. Thank you, Harshal sir, for the wonderful presentation. So if now anybody is having doubt, can ask in chat box. I will read it for you, sir. Is that okay?
Yeah,
Or you want
definitely.
to read
Thank
by
you.
Yeah,
yourself, sir?
yeah.
Okay. So we have one question. Mr. Amal asks, in corneal neovascularization is sclerosis indicated? Whether in
Okay,
this case
okay.
it
Yeah,
is indicated or not?
yeah. You can do it, but yes, you have to like be very much aware. Okay, you have to be very much aware that how much volt are you giving, what kind of a material are you using while fitting the while fitting the scleral lens. See, what is neovascularization? It occurs because of lack of oxygen, or else if there is insult at the cornea. Now you should remember that that scleral lenses, they are made up of hyper decay materials. You have got very good decay by T of 141. There are new scleral materials which are even available at 200 decay by T. Now that's really beautiful. So, but you have to make sure that you have to make sure that you do not give excessive vaulting while providing a scleral lens. So not insult the cornea anymore. In fact, if the patient has got neovascularization, if you fit a very nice scleral lens, probably the neovascularization would reduce as well, because the ocular insult has reduced.
Third question is from Mr. Vivek Yadav, who asks how to choose scleral contact lens for patients.
Okay, so as I told you, see, HVID is a factor, one of the most important factors that you take into consideration. So what I personally do is, the first things first, what I see is the HVID and how steep is the cornea. So the first thing what you take into consideration is HVID, because you have to make sure that the landing zone is at least 2.5 millimeters away from your limbus. So first things first, you measure the HVID, and if you think, okay, yeah, the landing zone is going to be far away from the limbus, you choose the first scleral lens, and you choose the scleral lens based on how high is the cornea or how steep is the cornea. However, the first choice of the scleral lens varies from company to company. Some of the company tells that, okay, if cornea is this much steep, then you choose this kind of a lens. If cornea is this much flat, then you choose this lens. They have their own nomograms. Some of the companies just say that you choose the median lens, and and then you make changes on it laterwards. So, choosing the first scleral lens would be based on the HVID, and then what kind of a sag or vault or base curve to be chosen, that will be that changes from company to company. And you start understanding it more once you fit at least 10 eyes. So you will understand by yourself that, okay, I need to choose this kind of a sag or this kind of a base curve, and so on.
I hope that is satisfactory answer for Mr. Vivek Yadav. So similarly, we have another question from Mr. Nitish. So Mr. Nitish asks if it is possible to make only mid zone and landing zone.
Um, does he mean that can we just change the two areas, or how is it like? Because see, scleral lenses have got 4 zones or 3 zones. I mean, you got to have all the zones in a lens, right? You cannot just choose any different lenses. But yeah, you can manipulate each zones, if that is what he is trying to ask. Because I'm not 100% clear with his question. If he can just come on the mic and talk about it, then I can understand it in a better way.
Yes. Okay, so requesting Mr. Nitish to please clarify on the question that you have asked, and so we'll be moving forward with another question. So Ms. Uma Maheshwari asks if, as scleral lens not touching the cornea, will there change in power calculation from corneal lenses?
Yeah, definitely. Because you wear the scleral lens with saline in it, right? So this saline acts as a, see, in RGP lenses. When you fit an RGP lens, there is a tear lens which is forming behind the lens and anterior to the cornea. That is a very thin lens. Right, so similar kind of a lens is forming behind the scleral lens and before the cornea, right? But this is a very thick lens system which is present. So yes, if you compare it with the corneal lens, the power calculation will change. But that is again not a rocket science. All you have to do is you just have to perform an over refraction, and whatever over refraction you're getting corrected, just do an algebraic sum along with the power in the scleral lens, and you get your power for the final lens order. But you have to make sure that when you perform the over refraction, that should the over refraction should be performed after the lens is properly settled. Settling time should be given. So some companies suggest 1 hour, some companies suggest 2 hours, some books will suggest you 4 hours. But I personally, what I do is I at least give 6 hours of time to all my patients. And you have to remember that whoever has got soft conjunctiva, they will take longer. They will settle more as compared to the people with other types of conjunctiva. Or in other words, we can also say that the old people, your geriatric population will have softer conjunctiva as compared to your young population. So there will be more sinking which you will observe in geriatric population. So the time of the overrefraction is something that plays an important role.
Thank you for that answer, sir. I hope this answers Mr. Maheshwari's question. Similarly, another participant named Optometrist MAK asks you for, which I'm guessing is any recommended course or fellowship about scleral contact lenses that you know of.
uh, See, fellowships always help. Anything learned is never wasted, right? So there are many institutes like LV Prasad in India. That's the best example. I'm not aware about about what can be done in Nepal. There are some other courses or fellowships in Australia. There's some in the UK and some in America. Now looking at today's condition, I don't think you would be able to visit any of those countries for the next 2 years. But LV Prasad stays as an option, but I don't know when you can visit India again if by chance you are in Nepal. But on the other hand, what I believe is if you have the right practice and if you're working at the right place and if you are given the right opportunity, so you can learn these things by yourself, by self study. You can read stuff on the internet, start gaining the experience, start doing the patients. You can do your own fellowship. So it's all about where you're working and what opportunities you're getting. I personally did not do any fellowships or anything, especially for sclerals or RGP lenses, but I got the right place to get exposed to all these things, and I got the right opportunities, and yeah, definitely I've worked for it. So here I am, and yeah, so I've never done any fellowships. So this depends upon you and what opportunities you're getting.
Very insightful answer. I hope that answers your question, Mr. Optometrist MK or Miss. So anyway, Mr. Himanshu was trying to ask us a question, which is a little vague. If I'll just read it out to you, sir. So, what is the role of two circle which one present in upper side of scleral contact lens?
Uh, Circle which is present where?
In the upper side of scleral contact lenses. Yes, that
Okay, I
one.
found
I think.
Himanshu Sapra. Yeah, sir. What is the role of two circle, which one present in upper side? Himanshu, can you please be clear a little bit with your question? I'm having a difficulty in understanding it.
Yes, yes.
Yeah,
Actually,
please.
sir, there is two circle, there's a upper side of contact lenses circles is present. I think so that in sometime I was confused. This is a right eye or left. I think so indicate it. So what is the main role of that circles?
You
The
mean
right
any
eye.
kind of dots? You're talking
Exactly.
about the
This dot
dots on
or
the circle.
is dot
Okay,
exactly.
okay. See, generally,
Hmm.
there are two types of markings which are done. Suppose if you're dispensing a lens to a patient, right? And
Right.
suppose if you're dispensing a right lens. So what many of the companies do is they give a dark spot on the peripheral on the on the transition zone basically, or at the landing zone. And if it's a left lens, they give two markings. So these marking not only say that it's a right and a left lens, but it also tells you that which is the flat meridian of your toric lens.
Okay. So,
Or
sir, how
suppose if
we,
you're go on. Yes,
okay,
go on.
sir, how we decide this is a right eye lens or left eye lens? Sometimes I get confused. This is right eye lens. How we get
Yeah,
to know
so
this is right eye lens
see,
or left
if the lens is in your trial set, then it's not a right or left lens. You can use any lens in any eye.
eye?
But
Okay.
if you have
Okay.
dispensed it to the patient, then these markings are present. You got to ask the company to give a tint on it. Many companies have micro etchings on it. They give laser markings on the lens. So
Mhm.
every company have got their own set of markings or indications for right and the left lens.
Okay. 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 Okay.
Is that is
Thank you,
that
sir.
satisfactory? Did you understand the point?
Mm, mm, Yes. 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 Yes.
All right, good.
Sure.
Yes.
Sure.
Can we have the next question, please?
Yes, sir. Thank you for that answer. So similarly, Amal has a question. How many hours can the patient use GP in a day? So he basically wants to know if can we change the saline and then we can use it for full day, like all of the waking hours.
Yes, definitely. So, the beauty of scleral lenses. Let's talk about, let's talk in differentiation between soft lenses and corneal GP and the scleral GP lenses. So, see, in soft lenses, we all are aware that there is very less tear exchange which is occurring under the lens, right? And we have got very less options for soft lenses, but these soft lenses are designed in such a beautiful way that they fit most of the eyes. So they can have 12 hours, 14 hours of wear without any issues, but very considerable spectrum of your patients start getting some difficulties after 8 to 10 hours, right? So you might think about going for a corneal GP. Now corneal GP is a floating lens. Okay, okay, it basically floats on your tear film. Okay, so what happens is at the end of the day, now suppose if the patient has got some sort of a dry eye. Okay, so there will be some difficulties. The patient again will start having difficulties because this RGP lens requires tears. Okay, there should be some tears to float on, and there should be some tears to be comfortable. So suppose if there is a dry eye, again the patient is gonna have some difficulties, and many a patients have got difficulty with the sensation as well. I would talk about the new patients or the new generation. You know, because the older generation used to wear just RGP lenses without any issues, the corneal GPs. But if we talk about the scleral lenses, now many of the patients experience something known as fogging. Okay, so anyone who is practicing sclerals over here will be aware of this term, which is known as the fogging. Now, what happens in fogging is that the saline which is present behind the lens, it gets foggy. This is due to the biochemistry of the tears, and it might is also occur due to the accumulation of debris. So yes, the patient can just change the saline and continue wearing. And if you have a patient who does not experience any kind of fogging, they can wear the lenses right after waking up to the time they go to sleep. So yes, they can wear the scleral lenses throughout the day without experiencing dryness or any other difficulties, as far as your fit is perfect. You understand? So a lot of factors come into play, but most of I shall say that 85 to 90% of your patients can wear these lenses during their waking hours without any issues.
Right. So similarly, moving on to the next question. So Mr. Manik has a question, and he wants to know the difference between vault and sag height.
Okay, see, sag is a term which is used, which is a lens parameter. Okay, the sagittal height is a lens parameter, and the vault is what you measure when the lens is on the eye. Okay, so when you look at that, the distance between the posterior surface of the lens and the anterior surface of the cornea, that will be termed as a vault. So vault is when the lens is on the eye, and the sag is the measurement of the lens.
Okay, thank you, sir. So that was, I hope that answers your question, Mr. Manik. Similarly, Amal has another question. So he wants to know the uses of anterior OCT in scleral lens fitting.
Very good. There are a couple of the most important. I can name two of them. There are more bifurcations after that, but let me tell you, the number one thing is to check the vault. Sorry. You can check the vault in the central region, mid periphery, periphery, and the limbal region, and so on. So the next thing what you can see is the landing zone. Okay, suppose if you're confused whether your landing zone is fitting perfectly or not, you can verify it on anterior segment OCT. You can see, you can focus your OCT on the conjunctival region or on the landing zone, and then you can see that how is the landing zone, and then you can take a decision.
Huh. Sir, we can check the volt with the Pantacam Stimflux image.
Uh, I have not tried it actually. So
Actually,
I
Pantacam
wouldn't say yes, I wouldn't say no. It's a Shimflung camera,
exactly.
but
While we
mhm.
capturing the image, I will capturing where there to look at the multiple pictures. On that basis, we can calculate the volt. Is it possible?
See, I'm not sure that I see. Regarding Pentacam, I'll tell you what I am experienced about. So Pentacam, I can read a report of Pentacam, but I've never operated the machine. Okay, we don't have it at our place, but we have it at our LASIK center. So I've never used the machine. But let me tell you, if this machine has got in the software a way to have a caliper or something which can do manual measurement, so yes, definitely you can check the vault.
Yeah,
But
there is a caliper
on
actually.
yeah, yeah. So you can use that caliper definitely, just like we use in the anterior segment OCT. You can use that caliper, and you can check how much vault is there.
Okay, okay. Thank you,
Yeah,
sir.
yeah.
Thank you, sir. So, similarly, Ms. Priyanka has a question. She wants to know what is the best trial set of Scleral to start with practice.
Okay, so each and every trial sets are really very good. Okay, if you are a newbie, or if you're just starting to practice, you can start with a corneoscleral lens set. But I wouldn't say that that is the best or the others are bad. I would say all of the sets are equally good, but I would suggest that you start with a corneoscleral or a mini scleral set. And if by any chance you can get any access to a company which can manipulate the landing zones and which can give you front surface toric, I think that should be your first preference, if it's an option at all. So if you don't have access to any such companies over there, you can definitely contact me and I can give you access to such companies, and we can definitely help you set up your trial set and stuff.
Okay, wonderful. So, I hope that answers your question, Ms. Priyanka. Similarly, Amal has another question. So, he asks if we can alter the landing zone after dispensing, like in row scale lenses.
In row scale, and you mean you're giving an example of row scale? Is that what you're
Yes.
telling me, or you're asking me about? Okay, okay, yeah, definitely. You can definitely make changes in it, but it's totally on company's discretion. So some of the companies give you two free changes. Some companies do not give you any changes. Some companies allow you one change after dispensing. Some companies have got a warranty of 3 months. So it changes from company to company, but again the changes may vary. And sometimes what happens is, if you give a steep landing zone, you can flatten it. But if you give a flat landing zone, so you cannot steepen the landing zone. You understand? So it also depends upon what kind of a landing zone you have already provided. And if you have given a custom landing zone and there is a very huge variation in it, so probably the company's insurance policy, I mean, the insurance for the lens will work for that. Or so this thing, yeah, can be done, but again the company would be the best people to answer about this. But what I would say that, yeah, something can be done on the same lens as well. There are a few things that can be done.
Thank you, sir. Similarly, Mr. Manish Mayer has a question. So, he wants to
Yes.
know how to get rid of fog after 3 or 4 hours of wearing.
Okay, so first things first, you gotta understand that why is the fogging occurring. Okay, fogging can occur at three levels basically. One is the anterior surface of the lens. It can occur due to dryness. Secondly, it can occur due to the defect in the anterior lens surface. Also, it can occur if the cleaning procedure was not correct, and there are some debris of the solution on it, so which causes the tear film to break frequently. And also scratches and so on to the anterior surface of the lens. The next area where you see fogging is in the post lens saline basically. It can occur when where there is an excessive impingement, when you have given a landing zone which is very steep. Or else it can occur when you have given a very high sag, a very high vaulting to the patient. Probably you have given 400 450 microns of vault to the patient. In such cases it might occur. Or else there is improper cleaning on the posterior surface of the lens, and there can be contamination of the saline. But if it is after 3 to 4 hours, so it could be the vaulting could be an issue, the landing zone could be an issue, as well as the biochemistry of your tears can be an issue. The mucin, basically there is a deposition, or there is a mucin which is floating around over there in your saline. So such kind of appearance is due to the mucin. You can see in Jogren syndrome or Steven Johnson syndrome. Mucin is one of the things. Definitely it will vary in condition to condition, right? Sometimes it could be lipids, sometimes it can be mucin. And the last and the most dangerous or the most fateful type of a fogging is when the fogging occurs at the cornea. That is corneal edema. You don't want this at any cost. So when you observe any fogging, if the patient says that my vision is getting foggy, you should really understand that why is the fogging occurring. If you have given excessive vaulting, please reduce the vault. That might lead to again, and I mean, recurrent edema to the cornea, and you might, damage the cornea. So at these three levels, you should understand at which level is the fogging occurring, due to which level is it occurring. But at any level, it can occur after 3 to 4 hours.
Okay, thank you, sir. That was a great answer, and I hope it answers your question, Mr. Manish Mayer. Similarly, Ms. Priyanka has a question. She asks, what is the specificity of scleral lens in treatment of particular condition of dry eye?
See, you're not treating dry eye. Let me tell you first things first. It is never a treatment. This is just reduction of the symptoms. Right. So in dry eye, let's say there's a Jogren syndrome or Steven Johnson's graft versus host disease and number of other dryness. So what is dryness? It is just lack of tear film. So what you're doing is you're giving a saline reservoir to the cornea. Right. So you're not treating. Once you remove the lens, it is back to normal again. When the patient puts up the lens, yeah, the patient has symptomatic relief as well as a beautiful amount of vision as well, quantity wise and quality wise. So you're not treating basically, you are treating the symptoms of the patients and you're giving symptomatic relief. But yes, in many cases of dryness, so, such as keratoconjunctivitis sicca, or where you see more and more vascularization of the cornea due to lack of tears, in such cases you can really have those cases because you're avoiding the vascularization of the cornea, and in some cases up to some extent there is a reduction in vascularization of the cornea. So you do a very good job in it, but specificity, I don't understand by what do you mean by specificity. I mean, if you can just shed some light on it, or if my answer is satisfactory, please let me know.
So, Ms. Priyanka, could you please come to the mic and tell us about the specificity word that you used in your question, or if he has already answered your question?
He's already answered my question. Thank you.
All right, great.
Okay, sir. So that was all of our questions. That was honestly a great session. I'm sure me as well as all of the participants have thoroughly enjoyed this session. So I would now like to request you to just share your experience in the e-learning session today.
Uh, are you asking it to me or to the participants?
No, sir, I'm asking you. I'd like to request you to just share your experience today.
I'm very happy with the amount of questions that were asked right now. So otherwise, the people have to answer that. How did they enjoy today's session? Whether they learned something new, whether it was confusing, or and so on. So let the crowd answer about that.
From the participant, we'll be asking through feedback form, sir. So no worries.
Yeah, definitely. You
One
can
question,
do
sir.
that.
One question, sir.
Yeah, please.
Hello.
Yes,
Sir,
please ask.
what is the first lens choice from the trial set for the patient? If K rating is 45 and 49 something,
Uh, okay.
how
So
to
as
that
I
lens
mentioned,
from the
yeah, yeah, good question. So as I told you that what kind of a sagittal depth or sagittal height you are going to choose, that will really depend upon the design of the lens you are using. So suppose I have access to 3 to 4 trial sets personally. So some of the companies have provided radius of curvature in it. So what they say is that you look at the average K reading of the cornea, and then you choose lens, the scleral lens based on the radius of curvature. Some other company says that you just whatever is the K reading, you choose the median lens. Some company says that you should be using this kind of a sag for these kind of readings, and this kind of a sag for flat readings, and so on. So it would really depend upon the type of the lens and the company what you are using. But you should once you fit a few lenses, you will understand that okay, this kind of, as you mentioned, that 45 and 49 are the K readings, so average will be somewhere around 47. So with experience you will understand, okay, if a patient's K reading is 47, then I will choose 4.09 sag, or I will choose 7.90 radius of curvature, and so on. Right, but it is not just the K reading of the central region which are important. You really should, look at the whole topography of the patient if you want to do scleral fitting very effectively and at one go. Initially you might have to choose 2 to 3 lenses, but once you get experienced, your trial will end in one single trial lens, and you can save a lot of chair time, and the patient also gets, pretty much confident about you.
Okay, thank you, sir.
Yeah. Well,
Okay, so any more questions from our participants? I think we're done with the discussion. So I have never seen such an interactive sessions, to be honest, sir. So I'm pretty sure the participants have enjoyed it. Anyway, we will be sharing the feedback. So on behalf of
yeah.
EyeBids and our audience, I would like to thank you for your time and the lovely experience and knowledge that you imparted on us today.
Yes, thank
And
you very much.
thank you, sir. So anyway, I would also like to thank our lovely audience for being so supportive, attentive, as well as interactive. And on that note, I would like to end our meeting. So stay tuned for more sessions and programs in the future. Thank you.
Yes, thank you very much. Have a good day. Stay home. Stay safe.